ما أريد من هذا الشعب إلا أن يزيد في الحمد والشكر إلى الله عز وجل، ويزيد من محبة الوطن، ويزيد من العمل ومضاعفة العمل لما يسعى فيه من خير له وللدولة والأهل. هذا اللي أنا أدوره من الشعب، وربنا إن شاء الله يوفقنا جميعا على ما يحب ويرضى.
يسعدنا اليوم أن نكون في هذا الحدث الطبي الهام الذي تنظمه شركة الإنماء للأدوية والمعدات الطبية للإعلان عن إطلاق دواء ميبتيد، وهو أحد أحدث الابتكارات في مجال إدارة الألم. ففي عالم الطب الحديث لم تعد إدارة الألم مجرد تخفيف للأعراض، بل أصبحت نهجا شاملا يهدف إلى تحسين جودة الحياة للمرضى. واليوم نلتقي بخبراء وأطباء لمناقشة هذا النهج الجديد الذي يعيد تشكيل مفهوم علاج الألم بطرق أكثر أمانا وفعالية. يشرفنا اليوم أن نطرح أسئلة محورية على عدد من الأطباء والاستشاريين لنتعرف على آرائهم حول هذا الابتكار العلمي الجديد. We are delighted to be here today at this important medical event organized by Al-Inmaa Drugstore and Medical Equipments to launch Meptid, a new and innovative approach to pain management. We will be speaking with leading doctors to hear their insights about this promising innovation that may reshape the future of pain treatment. استشاري تخدير، أهلا وسهلا بك.
مرحبا، أهلا.
اليوم طبعا جئت لتحضر فعاليات هذا الحدث الطبي المميز. اليوم نتحدث عن ميبتيد، وهو دواء جديد لإدارة الألم. من خلال خبرتك دكتور في المجال، حسب رأيك إلى أي مدى يجب على مقدمي الرعاية الصحية أن يتحصلوا على أدوية جديدة لتكون أكثر فعالية وسلامة في مجال إدارة الألم؟
شكرا، سؤال جيد جدا. طبعا مهم ان دائما يكون في اشياء وادويه جديده لعلاج الالم. علاج الالم مهم جدا في مجال التخدير والعنايه ورعايه المريض قبل او وبعد العمليه الجراحيه.
نعم.
هذا من اساس عملنا كاطباء تخدير، وهي شيء مهم جدا جدا، لان ازاله الالم للمريض ليست مجرد الرفاهية، مهمة جدا لعمل الجسم وعمل الجهاز التنفسي والجهاز الدورة الدموية والقلب. يعني المريض بصفة عامة لا يشعر بألم شديد بعد العملية، ويسهل في عملية النقاهة انه يشفي من بعد عمليته. فالأدوية المسكنة للآلام من مئات السنين موجودة وتطورت مع السنوات. فحاليا يعني في أدوية جديدة دائما يتم اكتشافها وصناعتها، وأدوية طبعا زي ما نعرف إن ما فيش أي شيء إلا عنده سايد افكت
أكيد
أو أعراض جانبية زي ما يقولوا. فالأدوية المسكنة للآلام معروف عنها أن هي أعراض جانبية كثير بالنسبة للمريض، من ضمنها الغثيان واللوعة والنوزيا، فوميتنج، الألم، وتأثيرات على حركة الأمعاء وأمور زي هذه. من المهم جدا أن أي دواء جديد يتم اكتشافه واستعماله لازم يتم دراسته بعناية، أنه يتأكد أنه أعراض الجانبية أقل من الأدوية اللي موجودة حاليا. لأن تقليل الأعراض الجانبية مهم جدا في علاج المريض في فترة إجراء عملية جراحية. هو فترة يعني عصيبة جدا بالنسبة للمريض. لهذا سبب وجودي هنا، اللي نشوف الأدوية الجديدة الموجودة ونتعرف عليها ونتعلم أشياء جديدة. وإن شاء الله يعني تكون من الأدوية الفعالة وفي نفس الوقت أعراضها الجانبية أقل من اللي موجودة حاليا.
نعم، مشكور دكتور.
شكرا جزيلا.
دكتور علي حرب، أخصائي تخدير، مرحبا بك.
أهلا وسهلا.
إذا اليوم مثل ما أرى أنك متحمس جدا لحضور هذا الحدث الطبي الكبير لمعرفة مدى فعالية ونجاعة ميبتيد. اليوم دكتور مثل ما نعلم أنه هاجس أي مريض هو تقليل الألم، خاصة بعد العمليات أو حتى بعد التعرض إلى الحوادث. فدكتور، أنت اليوم من خلال اختصاص حضرتك إلى ماذا تعتمد عند تشخيص المرض وكذلك عند وصف الدواء المناسب له؟
أول شيء أهلا وسهلا فيكم. إن شاء الله بنعطي جواب وافي على هذا الموضوع. هاجس المرضى دائما بيكون هو انه هل سأعاني من آلام بعد العملية؟ هل يعني استيقظ بحالة سليمة؟ هل الوجع بده يكون قوي او مش قوي؟ فلذلك بهذه الحالة بالذات نحن بنقيم الليفل تبع المرض، عرفت كيف؟ او تبع الآلام بالأحرى، وعلى أساسها بنحدد الدوز وبنحدد العلاج المناسب اللي بيخلينا بنفس الوقت نحافظ على وضعية المريض، ما نخليه يروح بموضوع الثبات او بموضوع يعني انه الألم المسكنات تهديه زيادة، بحيث انه نحافظ له على وعيه ونحافظ له على النفس ونحافظ له على حركته الطبيعية.
نعم.
اختيار الدوز هو مهم، اختيار الدواء مهم جدا
حسب حالة المريض،
حسب المريض وحسب حاله وحسب العملية، وشوف في عنده كمان مشاكل صحية تانية يعني باراليل، يعني نشوف الضغط، نشوف السكر، نشوف إذا في مشاكل تانية، على أساسها كمان بنحدد.
نعم. مشكور دكتور على كل هذه المعلومات القيمة.
أهلا وسهلا فيكم. وإن شاء الله اليوم عندنا الميبتيد بيكون نقلة نوعية بالعلاج والمسكن، هو مسمع بالدول الأوروبية، إن شاء الله يكون بالإمارات ببلدنا الثانية، نختار الأفضل ويكون شيء للمستقبل بيفيد البشرية والإنسانية
إن شاء الله. الآن نرحب بضيفنا الكريم وهو الأستاذ الدكتور طارق سلطان، وهو دكتور في الطب، استشاري في علاج الألم والطب التجديدي، وخبير في مكافحة الشيخوخة والحمض النووي، استشاري تخدير، ومتحصل على البورد الأمريكي للطب التجديدي، متخصص في إدارة الألم وطب مكافحة الشيخوخة في دبي، وباحث في كلية الطب بجامعة فلوريدا الولايات المتحدة الأمريكية. مرحبا دكتور.
اهلا بحضرتك يا فندم.
ما شاء الله بكل هذه الخبرات المتحصل عليها قررت اليوم مواكبة أحدث التطورات الطبية وحضور هذا المؤتمر الطبي. إذا دكتور، من خلال خبرتك في مجال الطب ومجال علاج الألم، ما هي الفئات الأكثر استهدافا أو الفئات التي ستستفيد أكثر من دواء مبتد؟
اولا اهلا بحضرتك واشكر حضرتك على استضافتي في هذا البرنامج.
مشكور.
حضرتك المرضى التي تعاني من الآلام المزمنة ما أكثرهم في هذا الزمن؟ آلام الديسك، ديسك الرقبة،
نعم.
ديسك العمود الفقري، أسفل العمود الفقري، آلام المفاصل. الكثير من المرضى تعاني من آلام شديدة بالعمود الفقري والمفاصل، وللأسف أكثرهم ملوش علاج إنما بياخد مسكنات. وهنا المشكلة، المسكنات اللي بياخدوها تبقى أغلبها، مش هقول كلها، أغلبها مسكنات تحت بند الناركوتكس أو تحت بند المخدرات. كلمة المخدرات هي أنواع من أنواع الأدوية المخدرة اللي هي بتذهب الألم ولكن لها أضرار شديدة ومنها الإدمان. يعني المريض اللي عنده انزلاق غضروفي أو عنده أي آلام مزمنة يلجأ إلى المسكنات، يبتدي جسمه يتعود عليها، يروح للي أعلى منها اللي هي الحاجات المتوفرة من الأدوية المخدرة. دي بتبقى اسمها أدوية في جدول، يعني ما بتصرفش إلا بروشتة طبية معينة. للأسف الأدوية دي بتودي الألم لأنهم غلابة لكن تؤدي إلى الإدمان، وهذه هي المشكلة. بقيت مدمن أدوية مخدرة. هنا بيجي دور النهارده، والدواء المطروح النهارده ده نوع جديد من الأدوية بيديكي كفاءة الأدوية المخدرة اللي هي الناركوتكس، اللي هي أدوية المخدرة للآلام، لكن ليس لها أي أضرار وليس لها أي مشاكل أخرى كالإدمان. فهو ليس بالحقيقة مخدر حقيقي.
نعم، إذا هذا الدواء هو أكثر فاعلية أو على قدر من الفاعلية مع الأدوية الأخرى، لكن أقل
ضررا.
نعم.
ولا يوجد فيه إدمان.
ممتاز.
زائد تجنب أشياء أخرى بسببها الأدوية الإدمان كلها تم تجنبها، لأن الدواء ده ليس من الدفتر بتاع المخدرات ولكن بنفس الكفاءة، وقد تكون أفضل في علاج الآلام المزمنة للمرضى.
ممتاز. مشكور دكتور على إفادتنا بهذه المعلومات القيمة.
تحياتي وأهلا بحضرتك.
Dr. Manish, the head of Astor Hospital. Welcome and thank you for joining us today.
Thank you, it's my pleasure.
Thank you. So today, based in your opinion, doctor, so which patient populations will benefit the most from Meptid?
I feel that pregnant patients can benefit from Meptid, and because the amount of drug that is transferred transplacentally to the baby is comparatively less when we compare to other opioids. So in my opinion, they can benefit better with Meptid.
Pregnant. Thank you, doctor, for giving us these informations. Hi, Mr. Ahmed. Thank you for joining the event.
Thank you so much. My name is Hafiz Ahmed. I'm pharmacy manager in Burjeel Hospital, Dubai. Thank you for inviting us for that fruitful session.
Yeah, thank you. It is our pleasure, Mr. Ahmed. So after this valuable discussion, what do you think about Meptid?
Really, it was really significant session was which we received today. It was very fruitful discussion what have done. I think Meptid, it is a very good analgesic, especially for the labor pain and for trauma, and especially in ER cases. And I hope in the very future it will replace the tramal injections for acute pain and for labor pains.
Thank you. It is our pleasure.
Thank you.
Actually, we're very happy to have you all here today. And we're very excited to have such elite audience attending tonight for our presentation. And it's going to be a great opportunity for us to introduce a breakthrough in the pain management And actually, it gives me a great pleasure to be here today representing inmaa. I'm Kamal Soufi. I'm actually the general manager of the college of biology. And then he had his postdoctorate in Novartis. He's the head of the medical department, global head of medical department for Bison organization. He devoted all his career in developing products, working to improve patient compliance, patient quality of life, and so on. I will not do any further today. I will just give the floor to Dr. Haiko, please.
Thank you, Dr. Kamal. I hope you can all hear me well, so microphone is working. To talk about one of our core products, which is peptide. I'm excited to have such a big audience and experts sitting here. And just as said, we came over from Germany. Headquarters of Jasim is in Germany, and I'll quickly show you a little map where you could find us once you visit Germany. Always open doors to have fruitful medical scientific discussions. And we will talk about peptide, a little bit about where to use it, what's the relative potency. We will touch on the mode of action, how it is metabolized. Then we will look into some data about general pain management. Special focus later on will be a snapshot on labor pain. And of course, as it's also an opioid, we always have to have a little look on the safety and precautions, and we will conclude with a small summary, and afterwards we will have hopefully a fruitful discussion, question and answer session. So if you are familiar with Germany, you can see here the map of Germany, and Fellbach, where we have our headquarters, is slightly north of Stuttgart. So whenever you are around in Stuttgart, feel free to reach out and visit us. The company was founded in the beginning of the 80s, and one of our core products is around the essential element selenium, because one of the founders, Dr. Stiefel, had his PhD on this essential element, and that was the foundation of the company. We had three founders, Mr. Kottwitz, Dr. Porcher, who sadly is not among us anymore, and Dr. Stiefel, and you can see them here on the left side. This is Mr. Kottwitz, on the right side is Dr. Stiefel, and in the middle we have Mr. Folzen-Bugel. He is currently our CEO. How do we do business as a company? We have our own core markets in Germany where we do everything by ourselves. However, internationally, we use strong partners for the delivery of our products, of our medicine, of our value to patients. You can see here in the countries where we have our products in Europe, internationally or globally. You can also see we go from the American side to the up to the Asian side, and now with inmaa here in UAE, we will have a strong partner for another core product, and this is our peptide. Pain management, you probably know better than me, is very important for patients. Comfort, satisfaction, recovery, also preventing development into chronic pain, psychic health benefits, and of course, pain management can also shorten hospital stays. However, not always everything goes along plan, and sometimes you have to rotate opioids due to inadequate analgesia, drug-drug interactions, or other things that result in changing of the opioid use. And here we think, or I'm a strong believer, that peptide offers a very good addition to to your arsenal to control pain, to, in the end, improve overall health and patient outcomes. And I also think that for the modern healthcare system in UAE, this can be a really essential asset. What is Meptid? Meptid is meptazinol, better said, it's meptazinol hydrochloride, and if you want to read the long chemical number structure, you can read it here. Comes as an injection solution and can be used for moderate to severe pain of various causes. So there is no real indication saying you can only use it in traumatic pain or in post-operative pain. It's very, very broad. Everything you can think about where you need pain control via opioid, Meptid is approved. Posology-wise, of course, it's always the decision of the treating doctor, and the usual dose that you use is either intravenously between 50 to 100 milligrams of meptazinol, or you can also use it intramuscular. Here the dosage is around 75 to 100 milligrams. And you can subsequently give more to the patient every 2 to 4 hours. If you calculate this up, if you say 100 milligrams every 2 hours, you will end up roughly about 1,200 milligrams, which corresponds to 12 ampules of Meptid per day. However, formally, there is no upper limit for dosing. When we look into the WHO analgesic letter, you know that oftentimes you escalate or de-escalate down these steps. Usually you start with the non-opioid analgesics like NSAIDs. Then you go to the next step, opioids, tramadol, tildine, codeine, and this is also where you could place Meptid or meptazinol in this analgesic ladder. So might be a good fit when you do not have to use already step 3 and when step 1 is not working or not enough. In order to compare its potency, those tables are always helpful. You might have seen such tables already. Usually the potency is always normalized to the effect you see for morphine. So this is why morphine is set to 1. And if you compare the other opioids here on the list, it just reflects if I want to have some receptors have a different profile of what they can induce, which might also be events that we do not know, like respiratory depression or hallucinations. This is what is downstream of signaling of these receptors. But there is not the end. We also know that within these groups, there are also subgroups, like in the mu, we have the mu 1, 2, 3, or in the delta, we also have delta 1 and delta 2. To make this a little bit even more complex, these receptors can do homodimers or heterodimers, resulting into different stimulatory pathways, signaling pathways, depending on how a molecule binds to these receptors. So in the end, the side effect profile of any opioid is always or depends on how these different receptors are bound, how strong the signal is that gets triggered downstream. In analgesia, we mainly want the analgesic effect. Not so much, of course, we want respiratory depression or euphoria, dependence. Sometimes we might want to have more sedation. Sometimes we might have or want to have less sedation. So how is this with Meptide? Meptide is selectively binding to the mu1 type of opioid receptor, while mainly skipping mu2. And what we know about these receptors is that mu1 is mainly responsible for analgesia, while mu2 is more responsible to induce respiratory depression. And meptazinol selectively binds as a partial agonist to the mu1 receptor, while only having a very low affinity for the mu2 receptor, thereby conferring less respiratory depression. When you look into the SMPC, you might also find a note where they claim that some of the analgesic effect may be supported by a central cholinergic effect. However, this is data which we only have from mouse experiments. So now when we compare affinities, so how good and strong a molecule binds to a certain receptor, such table can also be of help. And you can see on the bottom, morphine, our standard, let's say, has a certain affinity to mu1, a certain affinity to mu2, then to delta and to kappa. And if we look for meptazinol, we also have a certain affinity here and a certain affinity here, while the affinity versus these receptors is very, very low. Why do I highlight this? Because if you just look for the factors, morphine between mu1 to mu2 has a factor of 2, and meptazinol has a factor of roughly 9 to 10. In order to make this a little bit more graphical sound, I tried to draw some situations. Let's just assume we have the mu1 and the mu2 receptor and 10 molecules of meptazinol. When we give this to the patient, around 9 of the molecules will bind to mu1 and roughly 1 will bind to mu2. If you remember, in morphine, 3 would bind to mu1 and roughly 1/6, so 3 to 1 or 6 to 3 would bind to mu2. And this elicits then a downstream signal which is rather good to mu1 and less to mu2. So the analgesic effect is triggered while the unwanted signals are not really strongly triggered. If we now add more, like when we do dose escalation and dose escalation studies, at one point, of course, we will have the optimal dose, which will result in the optimal signal and the optimal analgesic effect. But also we will start binding to these receptors more. However, affinity is low, signaling strength is low, so the increased signaling is not really strong. And also we have a ceiling effect. So at one point, when the receptors are triggered, you will not get any more signal by giving more meptid. So in this case, of course, we saturate all the mu1 receptors. We will start binding more to the mu2 receptors. This might increase a stronger signal, which might result in respiratory depression. In reality, that's not truly the case, because in these higher dosages, we more see dysphoria than respiratory depression. Dysphoria also reduces, of course, the addictive potential of meptazinol, so there's a less likelihood to induce addiction. This is underscored by a study and also from our SMPC that clearly shows that meptid is not really similar to morphine, especially in the higher dose range, where it is clear that When given to opioid-dependent patients, even the higher doses did not really induce euphoria, but dysphoria. So the likely scale on how I like it was lower on the LSD scale, and there were more reports about nervousness and stomach illness. And overall, in conclusion, Meptide is considered to have really a very low potential for addiction. Regarding overdose, up until now, we have not seen a report, or even in the safety database, a report about poisoning due to significant overdoses of Meptide in humans. In some studies, even 7 times the usual dose was used, which did not result in any respiratory depression or in death. Of course, if you do toxicity studies in animals, at one point you will also see toxicity in the animals, which might then also have received lethal doses, and those were then characterized by central excitation and convulsions. Let's have a look on bioavailability and half-life of Meptide. And here you see comparison between Meptazole intravenously and roughly 8 to 10 times more Meptide orally. You see that the peak levels is very high when you use intravenous Meptide. Orally, the bioavailability is not as good. And from here you can also calculate the half-life, which is around 2 hours. When you put this in context and say that IV is 100% bioavailability because it's directly into the veins, compared to intramuscular, you also see that the bioavailability using it intramuscular is equally good as intravenous. However, the rectal route or the oral route does not really provide a lot of molecules to the receptors, and therefore Meptide is only approved for intravenous or intramuscular use. In regards half-life and repeated dosing, here in this sample you see Meptide given every 4 hours. And you see here at the beginning the peak levels, and at the end the peak levels. Here in between you only see the trough levels. So when you give every 4 hours 50 milligram, it corresponds to a single dose. So we do not have a real accumulation due to also the half-life. Another benefit, which I think is quite important for this molecule, is that we have very low plasma protein binding, and as you know, binding to proteins might induce protein drug interactions negatively, and also might block some molecules to reach their target receptor, thereby reducing effectivity. And similar to morphine, Meptide has a rather low plasma protein binding, which is really good. Regarding metabolization, and now we look into the liver. As you know, we have phase 1 and phase 2. Phase 1 uses the CYP protein complex for metabolization. Then those modified molecules go to the phase 2. And here's also different. Meptide is not metabolized via the phase 1 or the CYP system, but by the phase 2 system via glucuronidation. And roughly 90% of Meptide is metabolized without any active metabolite. So once broken down, it's gone. It's not triggering any receptor anymore, and it's excreted via the urine. Why do I do this differentiation to other opioids? because a lot of opioids use the CYP system, and you might be more familiar than me with that. But the CYP system, and you see here some core CYP enzymes which are relevant for metabolization. The CYP system is used by all drugs, or by many, many drugs, and also by natural products, which then can influence the activity of those enzymes. What do I mean with this? And I give you an example. So if you have an opioid which uses the CYP3A4 enzyme, and you perhaps, like St. John's wood, you increase the activity of the CYP enzyme, you increase the breakdown of the drug, you will have lower drug levels, and you might lose efficacy. On the other hand, we know that, for example, grapefruit juice can reduce the activity of this enzyme, which then can inhibit the breakdown of the drug. Drug levels increase more than wanted, and we increase the risk of adverse effects. Now, I don't know how common St. James wort or grapefruit juice are here in Dubai, but there are also other medications which might be used that can either induce or inhibit this enzyme. And I think this is very nice to know that Neptip omits this phase, goes via glucuronidation, reducing the risk of drug-drug interactions and negative interactions here. Now let's look at some efficacy data. And here you see a comparison between 50 and 100 milligram heptazinol versus 5 and 10 milligram morphine. And as you see, we have a quick onset with actually comparable peak levels corresponding to the corresponding dosages. So here you have the 50 and the 5, and here you have the 100 and the 10 milligrams. Same peak pain relief levels, while of course due to the short half-life, Neptide loses efficacy a little bit faster. Another comparison regarding pain relief, and this is a little bit different approach here. You can see what was done. There was a loading dose, a bolus of 50 milligram heptazinol and 5 milligram morphine, and then we had a continuous gavage, and you see as well, compared to placebo, we see a significant pain reduction, which is very, very quick, reaches the peak roughly about 30 to 60 minutes, and then can be maintained by the pump up to 24 hours without problem. Why do I show you these data as well? Because regarding the respiratory effects, they saw a difference here. Measured by CO2 or carbon dioxide sensitivity, you see that we have a different profile and a clear separation between Neptip and morphine, and the Neptip quickly goes back to the placebo level regarding carbon dioxide sensitivity. This was tested also in another study where not only Neptip and morphine was compared, but also pentazocine. In principle, the same result. The carbon dioxide slopes were significantly different from morphine or pentazocine, closer to the placebo effect on the respiratory system. In this study here, Neptip, pentazocine, and etidine was compared. In regards of pain reduction, all these three compounds were similar. There was no difference. But what was seen is that the sedation is less with Neptip than with the other two compounds. And in a German textbook on opioids in medicine, there was another calculation that was done. Here you can see diamorphine was set as 100% sedation potential. And then these three opioids were compared to diamorphine, and you see that Memteed also here has the least sedative effect. We are talking about an opioid. Opioids do PONF. We know that. Nausea, vomiting can be related to opioids. There is no real difference between Memteed and other opioids. Causality is always a question. I also work in pharmacovigilance. Sometimes all these procedures the patients have to go through, pain itself can also cause it. So there's nothing unexpected here. And from the feedback that we receive from the field is that if you have a good anti-emesis protocol established, these products work quite nice. And now more and more ondansetron is also used to control for PONF. Acute renal colic. Also a very, very interesting study. Here you saw 60 milligrams methazinol IV compared to buscopan compositum in patients with acute renal colic. And as you can see, onset of efficacy and also the effect of complete pain relief was very, very good, and considered even better than the use of buscopan compositum. Therefore, I think it's also usually when you treat with NSAIDs and they are not enough, you might consider going to the step 2 opioid, Memteed, and not directly to step 3. Plastic surgery, cosmetic surgery, tolerability of laryngoscopy or intubation. In this study, Memteed was compared to nalbuphine and fentanyl. They were injection followed by induction with a barbiturate and a muscle relaxant, and the blood pressure and heart rate was monitored. And as you can see also here, the effect on the cardiovascular system was not as strongly affected as with nalbuphine or fentanyl. Looking at the depth of anesthesia, also the effect of Memteed was minimal, so measured on the B-spectral index, also Memteed has a very low impact on anesthesia. And this was, according to the authors, very interesting because there is no cardiovascular stimulation and no increase in the B-spectral index, although the analgesic effect was 7 times lower than with nalbuphine or even 2,000 times lower than with fentanyl. And they then also discussed how this could be, and the authors attributed this superiority of Memteed in the reflex blockage, that it's probably based on a supraspinal and spinal mechanism, and also the lack of EEG arousal might be based on a better initial subcortical antinociception, as well as a better subsequent dampening of the cortical reactions. So this part concludes more the part of postoperative pain control or preoperative pain control or renal colic. So now we go to another feature which is quite unique for Memteed, and that's labor pain. Because apart from the normal pathology for overall pain from various sources, Memteed is approved and this is rather unique for opioids, during the first stage of birth. And here also another dosing can be emphasized, which is body weight adapted. So the more the delivering mother weighs, the more Meptid you can use or should use. You can even go for an exact dosing for 2 milligrams per kilogram body weight, and again, injection is possible every 2 to 4 hours. Just for those of you who might not remember what labor pain and the stages of birth are, the first stage of labor usually emphasizes uterine contractions and cervical dilation, and usually it's around maximum 12 hours. Usually it's quicker. Then it's followed by the fetal expulsion and the delivery of the placenta. And in this first stage, you can use Meptid in labor. The half-life does not change in pregnancy, so you can use it similar as in non-pregnant persons. You can see here that the curves are comparable, similar. Also here in pregnancy, you cannot see the real accumulation of methaxinol in the delivering mothers, even after repeated doses. And from pain control, and you might be familiar with Petidin or use Petidin, you see that we also have a quick, good pain control here. We even get some significant differences here at the 45 to 60 minutes time point, and then of course you will lose efficacy over time. However, works in pain relief during labor. Also, again, safety-wise, similar to other opioids, you can see nausea, you can have vomiting. However, dizziness, drowsiness, double vision looks like a little better using Meptid rather than Petidin. Now we are wondering not only about the delivering mother, but also what is the potential effect on the child. And when we look at these data, we see the level of Meptid 1 hour before birth, and the corresponding color here is the level of Meptid in the newborn. And you see that within 8 hours, almost all Meptid is already gone from the baby. And just focus here on the time scale. So here it's 24 hours. The same data with Petidin, you see that there is also very high levels, and the level within the newborn almost always equals to the mother. And also you have long circulating metabolites up to 96 hours. So I think having a short half-life in this situation is really beneficial. Coming from the scientific data or clinical data slowly to an end, I would just wanted to bring you also some real-world data from Level 1 Perinatal Center in Germany with roughly 450 births, where Meptid, Petidin, and local analgesia were compared. And of these patients with local analgesia, 130, so 77%, received primary local analgesia, and 23% underwent opioid therapy before local analgesia. Unfortunately, in this trial, we had no idea about what was the true dosing. It was just written according to the common protocol they use, what I read is they used Meptid in the range between 50 and 100 milligram, which might be lower than in other delivery centers that use the dosage table that is also provided. What was seen here? Roughly 1/4 of the female delivering or mothers to be need another injection of peptide compared to peptidin. And also the time to the next dose is roughly around 2 hours, which nicely confers to the half-life of Meptid, but also shows that in practical use, it's also done. So it's not that pain comes back, patient doesn't receive anything more. No, you can easily provide another dose of Meptide here. The difference that was seen is that with Meptid, less secondary analgesias were necessary than with the use of Petitid. And why that also might be of interest is because we know that if we have local analgesia, we will significantly prolong the whole birth process. And this is just in a table, a summary. As I said, we will have a significant longer birth duration when we use RA instead of an opioid. From the adverse event perspective, there was also no true difference. So delivery itself can cause nausea, emesis. You see here, this is comparable, no significant difference. The significant difference was only in the use of forcing the delivery again, in the use of oxytocin to push the delivery again. Looking into the babies, there was also no significant difference in all the readouts that are important for the babies, from APGAR scores to umbilical cord pH, respiratory assistance, breastfeeding successful. So no difference here between these two procedures that are commonly used during delivery. Maternal satisfaction for the pain relief was better with regional analgesia. However, this better satisfaction you buy it with a significant longer birth procedure. So what you can expect from a safety perspective? Yes, as I said, nausea, vomiting, you can expect it. You can do anti-emesis that should control this adverse events. Commonly you might find a little tiredness, dizziness, or the patients might sweat. Uncommon is more stomach and intestinal disorders, or diarrhea, sometimes a little bit drowsy or headache. Respiratory depression is really, really very rare. In all the clinical trials that were done, no respiratory depression was monitored and found. This is perhaps after introduction into the market in Germany, and we just took over Meptide some years ago. This might have been entered at the beginning from the former owner of the product, that they perhaps saw one or the other respiratory depression. Where should we be precautious, or whether we have special warnings? Of course, opioid is always considered when we treat people who might already have initial drug abuse or are prone for drug abuse. Perhaps also important to know that it cannot replace someone's opiate independent people. So when you switch a dependent person, you might see withdrawal symptoms with Meptid. Also precautions, always when you look into liver and kidney function, I was highlighting that Meptid is differently metabolized than many other opioids. Be cautious, it's not a contraindication, so it can be used, but you should know what you might expect. And you might be cautious if there is already a reduced respiratory reserve or traumatic brain injury. These are precautions you also usually find with other opioids. What should you not mix or also be precautious about is if you have a patient that already takes some depressant effects on the central nervous system, like sedatives, tranquilizers, or neuroleptics, that can be a mutual increase, of course, in fatigue. And we know that, for example, drugs like diphenhydramine may potentially weaken the analgesic effect of Meptid, and as this H1 antihistamine also itself can induce these adverse events, there might be some amplification of these signals. Do we have incompatibilities? Not really many. However, if you mix Meptid with other injection solutions, please always check if it's really compatible, because if you mix Meptid with strong alkaline solutions, you will have a precipitate which might, if you combine it, clog your venal port. So even if you do it one after the other, probably rinse the port before going with the next one in order to inhibit potential clogging. I hope I could show you some interesting data and convince you about these points. You can see in the conclusion, I'm a strong believer that Meptid is really a good addition to an acid to control pain. It is rapid, it is effective. With a short half-life, you might envision several indications where you might not need strong and very long pain control. It's very unique in that you can use it in the first stage of birth. I hope I could show you that the risk for respiratory depression also in newborns is rather low. Risk of addiction is low. Might have less sedative effect as other opioids, and here just I have feedback, for example, from a surgeon who uses Meptid during tonsillectomy, and the adolescent kids are quicker back in the waiting room and quicker back to the stations, quicker back seeing the family. We talked a little bit about the minimal effect on the cardiovascular system and also on the metabolism, protein binding, potentially reduced risk of drug-drug or drug-other product interactions. Multiple doses are possible because of the half-life. We do not have a strong accumulation of Meptid when we follow the 2 to 4 hour dosing scheme, and also in the delivering woman or even in elderly patients, we do not need to adapt the doses. With this, for now, I would thank you and finalize, and just perhaps this can be stored, Meptid can be stored up to 30 degrees. You do not need to put it in the fridge. I know this is an area where outside you quickly have this temperature, but up to 30 degrees is no problem, no issue with Meptid. So I hope you enjoyed it. Thank you for your attention, and I'm open for questions and a fruitful discussion. It is an antidote if anything happened, any complications happen. Yes, it is an antidote. There is the usual naloxone antidote that can be used, which is also might be needed to be repeatedly. But as about breastfeeding. So I'm missing some information concerning this point because it accidentally happened, So but now there's no clear antidote till now. Now in the SMPC you can find that if you've had overdose, you use naloxone. Second point, you talked about the bioavailability of this. You can use the rectal, intramuscular, intravenous. Yes. What about metabolized in the liver? If the kidney has any rules in the metabolism or excretion? It's metabolized, no, it's really metabolized in the liver, but just excreted by the liver.
If so, is there any protocols you have? This is the first question. And I have some experience with pyritramid,
yes,
which is also a German product.
Yes.
Compared to pyritramid, how you can say it is safer, or what is the main difference between concerning side effects?
Yeah, this is always a question from, let's say, I'm not a physician, I'm a company employee, and I have always hurdles to compare anything to a competitor, so I'm not qualified to answer things about competitors. That's unfortunate.
Similar, but potency is different
yes,
between the two drugs. We are using, you mentioned also that prednisolone and some antihistaminics decrease the bioavailability of peptide.
Yes.
Is it the same with dexamethasone? Because dexamethasone is used frequently in our practice. So
this is just a passage. It may decrease efficacy. It can also may not. So you have to test this. Depending on the dose and not on the higher end. As you said, you can EM or IV give it 50 to 100 or 75 to 100 milligrams. I would start lower and see.
thank you so much.
It is metabolized in the liver, yes. Yes, and then excreted liver. I can only tell what's written in our SMPC, what the data say. Experience on that, I hope you will gather. And if you want to publish, we are always here to.
You mentioned that MEPTID works as an agonist on the mu receptor. I was wondering if it is a competitive agonist.
Competitive. It's a partial agonist, and if you use another agonist with higher affinity, you probably will release MEPTID and use the one with a higher affinity.
That would be my question, because, for example, I quite like nagodine,
yes,
because it's a competitive agonist, so
yes,
you can reverse an over effect of fentanyl, for example,
yes,
and the patient will still have an analgesic effect,
okay,
but will wake up.
Okay.
So that's the beauty of nagodine. So I was wondering if MEPTID has the same effect.
Would be interesting to see. So whenever you use it, and hopefully as frequently as you must, but you can let me know. It would be interesting.
I will try. Thank you.
Thank you, Dr. for interesting talk. I mean, we learn something new every day. When searching about this medicine, is actually a 50-year-old drug.
Yeah.
And maybe it's been underused for many years. But when I looked at the searches, what is mainly used for labor analgesia in Germany.
Yes.
But is it now getting more and they use it for other aspects of perioperative pain?
Yes.
Or still mainly in labor analgesia in Germany? I left England, the UK, 8 years ago. I've never used it there, so I'm not sure what happened the last 8 years.
Yes.
Is it now being used more widely?
I'm just honest.
Yeah.
We acquired the license for MedTech several years ago, then Corona hit, and now we are recovering and trying to expand this usefulness. So we are currently trying to see where MedTech would work outside labor pain.
Yeah.
Good indication is tonsillectomy seems to work nicely. We have feedback from orthopedic surgery, hip surgery, knee surgery, pain control. If again, step 1, analgesics are not sufficient, escalating to MedTech might be working. We have no clear line so far, but also inmaa has some great ideas with Dr. Kamal, really as a physician, also having a vision where this might be helpful, and he might want to comment on that. I think from the broadness of use, you can envision almost everything. Perhaps you want to have it in the elderly patient, or even in those where the cardiovascular system is not the best anymore. Perhaps cancer pain when it's not super strong, to reserve the stronger ones for later. I can play 1,000 scenarios, but I would like to learn, do you envision it somewhere?
Yeah, well, I like the idea of the less side effect, nausea, vomiting, less sedative, and the short action, so can definitely play a part in some, period of pain.
I mean, we have also, I have an emergency physician on the emergency car, and he likes to use it when he sends the ambulance to the accident. Until he comes, he just tells them, give him a tip, because then you have pain control, you load it in the car, you bring it to the emergency department. Depending on time, the patient is in pain control, but losing this control might be less sedated, might communicate with the takeover physicians for the further procedures in the emergency room, for example.
Yeah, with the study you compared it with morphine with regard to the side effect and how your molecule attached to the U2 receptor.
Yes.
Are there any study to compare it to the oxycodone IV? Not yet.
No.
Because currently we have both morphine, oxycodone IV, and oxycodone has less side effect than morphine.
Okay.
I'd be interested to
Yes. Yeah.
know.
Yeah.
Thank you very much.
Happy to hear from you.
My name is Jasim. I'm down with the company. Maybe if I would say something like to be like promoting something, but 6 months ago I had a really very bad accident. I broke 6 ribs, column bone, scapula. I was under tremendous pain. The pain management that time, okay, they tried to give me morphine, okay, but then they stopped because they said like where we are going, because I was reading. So that was more pushing me, okay, to bring lipid, okay, which is giving me the more energy to bring something like this can control pain, because I had that pain no one can imagine. In the same time, okay, they are not with pain management, they could not give me more than 1 week, okay, because they don't start reducing the pain. That's the method, okay, where you can give it for your patients, have the same efficacy and with less side effect, especially the addictions. So that's why now I'm commenting about you, Dr. Thank you very much for the questions. Really, where we can go with method. You can go with everything. Any kind of pain, because it's a painkiller. So we less side effects. And the morphine is a wonderful product. Okay? No one can doubt about it. Okay? But at the same time, we are afraid always of the morphine. So why not to give the method the chance, okay, with any kind of pain, and then observe. Okay? It's an old molecule, and all the painkiller is an old molecule, from non-steroidal to opioid to 30, 40, 50, 60 years ago. Let them give it a chance. Let's give our patient the chance to enjoy, okay, a painkiller without side effect. Thank you.
We reached the end of day one of this exceptional medical event where experts came together to discuss the future of pain management and the innovative method. It's been a day full of insightful talks, scientific exchange and a clear vision towards safer and more effective treatments. Join us tomorrow in Abu Dhabi for day 2 as we continue our coverage and bring you more highlights and expert perspectives from this remarkable event. في ختام أول يوم من هذا الحدث نقر بأن الابتكار في الطب هو البوابة نحو مستقبل أكثر راحة وصحة للإنسان. إطلاق مبتد اليوم ليس مجرد طرح دواء جديد بل خطوة تعكس تطور الفكر الطبي في إدارة الألم ليصبح العلاج أكثر دقة وأمانا وفعالية. من هنا من قلب دبي نودعكم لنلتقي غدا في اليوم الثاني من هذا الحدث في العاصمة أبو ظبي لنستكمل معا تسليط الضوء على أبرز الجلسات والنقاشات حول الدواء الجديد مبتد ونهجه المبتكر في علاج الألم. إلى اللقاء ونراكم غدا في تغطية جديدة.